I had people coming to me with evidence they had no atherosclerosis at age 75, and yet their doctor wanted them on a medicine to treat the cholesterol in the blood, which is a marker and predictor of atherosclerosis, a disease they didn't have. So, I mean, that's crazy that the diet change is a huge preventive, not only therapeutic, but preventive measure. And so when my patient goes to the doctor and the other doctor, they say, you need a drug for this. I coach them to say, but I'm changing my diet for this. So the diet is actually intervention that is as potent as a drug. Let the body heal itself without these supplements as best you can. Went home and I saw them at an appointment. They both lost over 50 pounds each. In my experience, this is around the year 2000, that never happened. You know, just spontaneous weight loss. So I asked them what they did. They told me they read a book.
Dr. Eric Westman is a professor in internal medicine and obesity medicine and world expert in managing obesity using the ketogenic diet. Dr. Westman, it's an honor to have you with us today.
My pleasure. Thanks for having me.
Thank you. And my first question is, what is insulin and why is it so important for weight loss and for overall metabolic health?
Right. Well, that's getting right to the mechanism of all of it, isn't it? Insulin it turns out, is a hormone in our bodies secreted by the pancreas in response to the blood sugar, blood glucose, blood sugar going up too high. Now, what is too high? Depends on the individual, but so the main concept is our bodies don't like the blood glucose to go up too high. In fact, if it's high all day long, that's called diabetes. And you don't want the long-term complications of diabetes. So insulin facilitates or helps the glucose get into the cells, specifically cells that don't just bring up glucose automatically, right? So insulin can help sweep the dust under the rug, so to speak. It gets out the glucose into the muscle cells mainly. And so what happens is the blood glucose goes down and then, you know, everyone's happy. Well, the body for a while can do that. And yet the insulin over time can not work so well if the cells are, this is the way I look at things. If the cells are too full of glucose, then they're not going to respond to the insulin as well, and you develop something called insulin resistance. So when you really kind of step back, it's not normal to have insulin go up and all the time and then even to stay high all the time. Then that's getting into prediabetes and diabetes. And but you know, when I talk about prediabetes and diabetes, I don't lead with insulin as the question. I lead with glucose. What is diabetes? And if someone says, well, not insulin, oh, wait. Are we talking type 1 or type 2? Type 1 is insulin deficiency. You need insulin. But type 2, there's already plenty of insulin in the body. And the problem is the body isn't using the insulin, or the cell is too full of glucose, so it doesn't listen to the insulin. And you know, the reason we have this perspective on insulin resistance, meaning the insulin's too high and that causes the insulin resistance, because we can lower the insulin and fix the insulin resistance. So that's how should I say, the reason we say this is the mechanism of insulin resistance. Insulin is too high, and then we ask, and I tell my patients, you know, the things that cause the insulin to go up are the carbohydrates. And if they don't know what a carbohydrate is, that's okay. I just give a list of foods to stick to. And but the main thing, I think, regardless of the diet that you're trying and lifestyle that you're trying, you want to keep insulin as low as you can. That's kind of the general theme of my lifetime, where we as internists, well, a lot of other internists still focus on cholesterol. I've made the shift from worrying about a cholesterol level to worrying about a glucose and insulin level in the blood as a major focus of health. So I guess that's my long-winded answer to what is insulin. It's something you want around just enough, not too much.
You tell us about your approach for weight loss using the ketogenic diet?
Yeah, back 25 years ago, two of my patients lost weight in front of me. They went home and I saw them at an appointment. They both lost over 50 pounds each. So this is, 20, 25 kilos. In my experience, this is around the year 2000, that never happened, just spontaneous weight loss. So I asked them what they did. They told me they read a book. It was the same book. Back then, and even today, there are books you can read. This one was the Atkins diet. And the Atkins diet is varying carbs, different carb levels, but the lowest carb level was a keto level carb restriction. So I use really what was called the Atkins induction or South Beach phase one or Protein Power was the other book 25 years ago. But there were all these books, but there was only one doctor who had a clinical practice doing this, and that was Dr. Atkins. So I went to visit him, and I asked, what do you do? And in fact, what he did in his clinic was stricter than what the books said. So I learned and then said, you need to do research, and I'll do it for you. So I came with a research proposal, and he wrote a check to fund one of the first studies on the diet that he had been using for 30 years. In fact, he said, why would I want to fund research? I've been using this for 30 years. This is kind of funny because he knew what the results of the study would be, well, at least in a select population like his clinic. But I convinced him that, and I didn't have to do it hard, to convince him that nobody else really believed him. And there was a big distrust then and even now in some circles, but 25 years later. So we started publishing papers on this. And so I tell my patients, to summarize this up, I didn't make this up. I've sought out the information and studied and published papers on the keto type of diet. And now, it's gone through LCHF, low carb, high fat, that kind of came and went. And then keto is, comes and goes, although there are food products in our area called keto, which largely I want people to stay away from, but at least the industries have caught on to that this is a name they can use. But so the name kind of changes, but the concept is the same going back to the 1860s in London. That's kind of the first diet book we know about, and it was a low carb diet. So I pull out that book when I meet people for the first time, and I pull out the diabetes book from 100 years ago and show, here's what doctors were using. And so I just keep the carbs super low. Just eat as much as you want of meat, poultry, fish, and shellfish, and eggs. And the little twist there is people don't want much. Eat as much as you want is kind of oh, well, this won't be so bad because I can eat as much as I want. But then people eat less automatically. They don't want much, which is kind of the beauty of this diet compared to other diets. Most other diets, you have to count calories and you have hunger. And in fact, I don't know many or any doctors in the US who are in the obesity medicine world. So I went internal medicine first, then obesity medicine. I don't know of any other doctor that uses the diet alone without medication other than a keto diet. So it can stand alone without pills and shots, and the shots have become massively popular in the US and all around the world, but you don't need them. If you can teach someone a simple version of a keto diet, it works just like the shots. Maybe not quite as fast, but then you don't have to have the shots. So the keto diet I use as compared to internet keto today is much simpler, and it's based on real food, not fake food. One of the big differences from internet keto is we use total carbs, not net carbs, for the strongest prescription strength version. Not that net carbs can't work, and it's a useful concept, but it just means more carbs So I use a keto level of carb restriction, total carbs, not net. Works well. If it clicks, that's all my patients need. Now, not I'm honest, not everyone can do it or wants to do it. My fruit, how can I live without fruit? But if you can get people through that first day or two, fruit flavored things, sugar-free things, it clicks with most people, but not everyone. And so I've kind of carried that torch of just using the diet by itself because a lot of people don't want shots and pills and they want to do something more naturally.
Yes, and it's more sustainable as well to stick to
Well,
food.
it is, and yet that's the thing you'll hear. Oh, well, no one can stay to that. It's not sustainable. Well, yeah, it is, and the twist on the shots is that's not sustainable. Well, the companies want you to be on them forever, but most people don't want to be.
We talked about briefly the net carb versus total carb, and you're also well known for page 4, and that's whatever is on that page people should eat, and whatever is not on it they should avoid. Could you talk to us more about the fundamentals of page 4 and the difference also between net carb and total carb?
Yeah, so the handout that I use in my clinic, I have two handouts. One goes over the detail of the plan. Don't eat unless you're hungry. So it's okay to eat one or two meals a day. So there's a lot of mindset change that occurs, but the food plan is basically on the fourth page of the handout. Thus, it became page 4. And I don't know, 5, 10 years ago, there were some rogue page 4s out there with fruit on it. So, be careful of which page 4 you find. But the essence of it is keeping the carbs under 20 total grams for the day. Some programs use 30 total grams, so somewhere in there. And that means you can eat as much as you want of zero carb foods. And you can look at a label and see what the carb content is. Of course, most zero carb foods don't come with labels. So that's the meat, poultry, fish and shellfish and eggs, and you choose what you like. If you don't eat pork, you don't need to eat pork. If you're allergic to eggs, you just don't eat eggs. I mean, so it saves a lot of time for me to just give a handout of the food because I don't have to go over your food preferences. A lot of dietitians they're taught to, do you like fish? Well, some fish. Do you like salmon? No, I like so and then they come up with a plan for you. No, I say, here's the list. Choose what you like and what you can tolerate and what fits into your scheme of whatever. If someone wants to do vegetarian, that's fine. My page 4 is really omnivorian. It's not just vegetarian, so you'd have to use some other sources of information. But those zero carb things are really what you key in on. Other people call them proteins. The eggs, chicken, poultry, fish, and meat is really, and meat meaning it could be bacon, turkey bacon. It could be spam. In some parts of the world, spam is used and consumed and enjoyed. In my area in North Carolina, southern United States, these pig skin puffed up called chicharrones or pork rinds are pretty popular. But if you don't eat pork, then there are these chicken rinds that are just puffed up chicken skins. So, you come up with different ways to get zero carb foods as a strategy over time to help people transition. But the other things that I've learned kind of looking back is that Dr. Atkins had worked out a system where there's a little area on the sheet that I use that has a limitation. And these are the high calorie items and the things that have trigger food elements, meaning you have a little bit, you want more. And so cheese, cream and oils and mayonnaise and all of these have a limit on the page. And that's something that's different than what's taught on the internet. I get people coming in now saying, well, I thought I could have cheese as much as I wanted because it's so low in carbs. I said, well, that's what the internet teaches, but the system that I teach has to work. People come to me and they want it to work the first time. And remember, I didn't make this up. I kind of inherited, I did my homework and sought out a clinic that had already figured out that, cheese has to have a limit on it. And then there's some other items on the page, and we do let people have sugar-free things to get over that sweet tooth, the urge, cravings for sugar. And then one of the biggest things that we've learned, I have a company that teaches this online called Adapt Your Life Academy, and we survey people at the end of the class, and nuts are a big offender for being a trigger food. And sometimes that's all people need to do is just cut out the nuts, and then the whole program starts to work. There's something about nuts that makes you want them and want more of them. And if you have full access to, a tub of cashews that are already, shelled, and then you're just going to overconsume the calories and the amount you eat. So I guess in summary, the list of foods keeps the carbs low, but then that keeps the calories low. And so people end up eating less than before without telling them to, which is really pretty amazing when you really step back without a pill or a shot. In fact, the research is now showing that what happens in the body is what these shots and pills do without the shots and pills. So it's almost like that saying of, oh, it can't be true, it's too simple, and it's too good to be true. But no, you can just change the food and get these drug-like effects.
Do you tell your patient to monitor their net carbs or their total carbs? And what's the difference between the two for someone who doesn't know?
Yeah, well, on the list that I give out, you don't even have to count carbs. So the list will automatically keep you under the 20 total carbs for the day. So I kind of discourage the use of apps and counting of carbs. Just stay to the list. And, I find my job is to make it simple, not hard for people to do. The idea of net carbs, so total carbs, meaning you count every carbohydrate in the food. If you look on the label where it says total carbohydrate, you use the total, although in some countries they put glycated carbohydrate, meaning they've already subtracted out the fiber. So you have to be a little bit careful, or just stick to zero carb foods like the meat, poultry, fish and shellfish and eggs is the workaround there. But net carbs is a concept that came around, maybe the year 2000, 2005. And I am an author on a book that used net carbs as the kind of way to count it. But I've never used that in my clinic. So there's always been a book teaching and then a clinic teaching. I've always used total carbs in my clinic, but the New Atkins for a New You, one of the books that I'm an author on with Steve Finney and Jeff Volek, we use net carbs in there. And net carbs is where you subtract out the fiber and you subtract out the sugar alcohols from the total. So you might have a slice of bread that has 15 total, but you subtract out 8 for the fiber and maybe 2 for any other kinds of sugar alcohols or sweetener. And so the net carb would be 5. In fact, we're seeing now products where they market them as net carbs of 0. So, but on the label it says, carbs 0. Well, you have to look at the fine print. It says net, So look on the label. Some of these 0 net carb breads, pastas, ice creams are actually like 10 or 15 total carbs. And so the reason that's important to know the difference is some people, those net carb, the things you're subtracting out actually do impact the metabolism. I mean, you can now know with a glucose monitor or a CGM glucose monitor on your arm, you can test these things. And someone came to my office recently, and I'm in a clinical practice, 4 days a week, 4 work days, and someone said, well, what about this new candy? I said, well, I don't know. Well, look, it says total carbs and then net carbs. And I said, well, have you tried it? And he said, no. And well, so we went online in the office and someone was YouTubing their own result of the candy, and the first one we saw was no effect of the candy. So using net carbs, it didn't raise the blood glucose. So I was, trying to teach this person, well, it could be that the insulin went up to keep the glucose down. We don't know. They didn't measure the insulin. So we checked another few people who had done it online, and someone ate that same candy, and the blood sugar went from 100 to 180. So what we're learning is that there are individual, well, duh, there are individual differences. We're not all the same. And so you could use these net carb things. But again, my perspective is I want it to work the first time, every time. I'm in an office where people have waited often for months to come see me. And I ask, do you want to play around, see if it works or doesn't work? And they say, no, I want it to work the first time, every time. That's okay, then let's use total carbs, 20 to 30 per day. Let's not mess around with net carbs.
Yes. You have talked about some of the trigger foods like the nuts and cheese. What are other examples of foods that say will be under the same category as trigger food?
Could be anything really, which is, of course, we're all different, but the most common trigger foods, meaning you can't stop eating them. So if I said, go ahead and have one handful of nuts, in my experience, about half the people I teach couldn't stop, couldn't moderate. So that's a trigger food. And if the trigger food happens, I don't know, more than 1 out of 10 people, in my experience, it's best just to tell people to stay away because I want to try to give people the best chances they can. So nuts, cheese, cream in the coffee, especially a certain demographic. If they used to have cream in the coffee, now I can have cream again. Because for so long they were taught not to. Then I say, show me how much cream you're having. This is the pour, the cup pouring into the other cup or the container, and you just want a little bit of cream. About 4 ounces of cheese per day, which is about 4 string cheeses, or you just have to kind of get an eyeball of the measurement there. Other common trigger foods are the sweet things. So berries and fruits. I know a lot of keto programs allow for that. Most of the people who end up in my office can't moderate berries and fruits and are quite surprised that I say no berries, no fruits. And well, bread can be a trigger food for people. So if I say, well, you have a sugar addiction, oh no, doctor, I don't have sugar, but I can't give up my bread. So for those who want to know, starches get digested to sugar. So bread gets digested to sugar. So it's really the same thing. When
Yes.
I say it's a sugar addiction, that includes starches. But there are some things that are, I would say, culturally dependent. I grew up with this peanut butter concept, Jiffy and Skip, and we had peanut butter and jelly on our breads. And, as a child, that's what we'd have for lunch. And I could have a whole jar of peanut butter that's a trigger food for me. So I stay away, have just a little bit. I'm careful about it. Mayonnaise can be a trigger food for people. Well, they tell me that they could eat the whole jar of mayonnaise, and while that doesn't sound appealing to me, so it really depends on the person. And often there's a little bit of shame and guilt involved with this. So it's best in the context of a relationship that you're building with somebody to then ask about these things. And it's even often hard for an individual to come to grips with that is a trigger food. And so you have to explain what that is. And so for some people, it's like an addiction even. And, with addiction, when I look back, I would go and take money from my mother's purse to go buy sugar. So the classic thing is to you steal to support your habit, and that's what I did as a child. And I told that once in an audience of a few hundred people, and everyone was kind of shocked that so I don't say that much. I don't think many people did that, or they suppressed the fact that they did it. But so trigger food really could be any food, although it's rare
Yes.
for those proteins to become trigger foods. It's rare for eggs and chicken and fish to be trigger foods. So that's kind of the safe area. And of course, it's the best nutrition. If you kind of switch gears of what we should talk about it, you want healthy, nutritious food. And that's a way to also to talk about food. You can use, well, we're having very high nutrition value food. And then that kind of takes away all of the sugar and all because that's so devoid of nutrition. You really want your anything you eat to be as high in nutrition value as you can, and drink too. Oh, let me bring in the sugary drinks. I mean, that's a trigger and all, but the workaround there is you, at least for a short time, just let people have sugar-free things. So, and I've noticed the shift in our stores and all that there are more sugar-free options, and the companies have matched the flavors a little better. I wondered why Diet Coke and Coke were kind of the only things for so long, or Diet Pepsi and Pepsi, because they don't taste the same. It's hard to get someone to go from Pepsi to Diet Pepsi. Now there's Pepsi Zero or Pepsi One, so the flavoring, it's easier to transition someone from full sugar sodas to sugar-free because there are more flavors that are available today, and I find.
Yes. And you talked about trigger food like cheese. What about cottage cheese?
Well, that's fascinating because it's not on page 4, all right? Cottage cheese is, although if someone can control it, it's fine. But just recently, someone asked me, "Where's cottage cheese?" And I said, "Well," and he says, "Well, because I can eat the whole tub." And I can't have it. So I quickly pivoted. I think cottage cheese, um, for a while, it becomes part of diet programs. It's historically grapefruit in the morning. It was part of the diet program, half a grapefruit, and because it's the least sweet fruit that there is, unless you put sugar on it. But now there's so many people on medications, and the grapefruit has a problem with stopping absorption of medications. You don't find doctors talking about grapefruit very much anymore. But if you're working with someone who's not on a medication, that's probably the least sweet thing. And so there were diet programs that had cottage cheese in it. And I think people learned that it's harder to stop that. So that's why it's not on page 4. But if you can moderate, staying under the 20 or 30 total grams per day, it would be okay.
So because it's a trigger food, you removed it from the list?
Well, see, I inherited the list, right? I went to a program, and I think this is important historically. The program was Dr. Atkins in New York City. It was a very diverse clinic, but I think what was allowed to be on there was a function of it being developed in New York. So you can alter what's on the list. I mean, this is when I teach other doctors, I'll send you the list if you want, and you can alter it. We did a study up in north of Vancouver in Canada, and we ended up putting things on the list like moose because it was so commonly consumed in that area. But in North Carolina, it's very rare to have moose. So you can change kind of the overarching concern is you want to keep the carbs super low. That's why there's a limit on the leafy greens and the non-starchy vegetables per day. Those are allowed on the keto diet that we use. 2 cups, though, of 2 fistfuls roughly of the leafy greens and 1 fistful of a non-starchy vegetable for the day. And so you could, whatever is commonly consumed in your area, adapt the list to that with that in mind, keeping the carbs under about 20 or 30 per day.
And the goal is to reach the ketogenic state. So it's try to use ketones as a source of energy instead of glucose? Is that the goal?
Yeah, well, in our experience, we don't teach people to measure ketones. So we don't ask them to take meter measurements of their blood glucose or their urine or breath. We know that just about everyone will be in ketosis or fat burning, or the new word today in publication now is called euketonemia. This is a paper by Dr. Isabella Cooper in London, where they took women who were already in ketosis means abnormal condition of, because if you look at carb eaters, it's not normal to have ketones, right? So you're called abnormal because you're not what's typically measured, but it doesn't mean it's bad, right? So normal can mean just what's not normally seen, or abnormal can mean what's not normally seen. So if you're not eating carbs, your body is burning fat, and some of that fat gets turned to ketones, and then that's why it's called a keto diet. But really, it's a fat burning diet, and your body has burned fat all along. It's just that if you're consuming lots of carbs, you're going to be burning those carbs first. So yeah, so I don't do a whole lot of teaching about ketosis at first, and unless there's some baggage, someone's worried about it, I'll try to dispel the concern, because everyone goes into ketosis if they don't eat for a day or two. It's basically the natural fuel source that we store on our body called fat that's being used. So euketonemia maybe will be the word of the future, but everyone learns it as ketosis. So the problem with ketosis as a word is that people in the medical field, doctors, nurses, dietitians, conflate that with ketoacidosis. And it's not ketoacidosis. So ketosis as a fat burning condition is what we want. Yeah. Yeah. And so you can get, well, most people come to me wanting to reverse diabetes or obesity or other metabolic problem. And fat burning is very helpful, because the obesity or the extra fat on the body is the root cause for so many of these things. So you do want ketosis, back to that. But ketonemia, you want to have some ketones around, and at least at first. I'm not yet convinced. Some people think of me as an early adopter of, no, I've been studying and using this for over 25 years, and I'm still kind of skeptical about those who are saying, you must be in ketosis every day, get my meter, and oh, by the way, here's the affiliate link, and where they make money from it. So the studies, at least the therapeutic aspects of a keto diet are solid. I mean, it's you would call that settled science. Yeah, that you can reverse diabetes, obesity, all these metabolic issues. It makes sense that that kind of diet would then be healthy to continue, right? And yet the kind of, well, I don't know, it's okay to use it to reverse these things, but then you better get off that. So I'm not sure yet. I think that's a great space for further research, that once you've gotten to this area of reversing your problem, or even like Dr. Cooper is doing, she took people who are age 30 who've already been in ketosis for 5 years, 3 to 5 years, I think was the average, and looking at all these metabolic parameters, it looked really good. And so now we're at that stage of, anyway, of maybe it is good to be in ketosis, or at least limiting the carbs forever. But if I brought that up in the first clinic visit, a lot of people would get scared and bail out. So what I explain is, there's a weight loss or a diabetes reversal phase, and then there's a maintenance phase. And you could do entirely two different things. You don't have to do the same thing. And, you can barter or negotiate to say, just try it for a few days or a week and see what you think. Some people say, oh, try it for 90 days and then you'll know. No, you'll know in the first week. If you do it strictly and you feel the hunger gone, the increased energy that most people get. And often I can take people off medicines in the first week. So, when you get into our internal medicine practices, I get people off medications that my colleagues, they believe that's the only way to do things is with medication. So I practice the best internal medicine of my life, actually using what Sir William Osler used 100 years ago. He's the father of internal medicine, at least in our world here. And they used a low-carb diet for diabetes 100 years ago. So the context matters, is what I'm trying to say, is that we can use this for reversal of conditions that other doctors who use medicine don't understand. And then whether it's something good to do, from birth or from after you've reversed all these things forever, I think it's an open question. It might actually be better, but I'm not convinced yet. I mean, I'm not an early adopter. I've been in this space for 25 years, which, as we were saying, it goes by fast if you're enjoying what you do. And I love going to clinic, and I've helped other doctors kind of regain their love of medicine because they wanted to help people in reverse conditions, not just manage them. And so just this last week, someone who had been on insulin for 10 years, in her 70s, 75-ish, she was off 80, so she was even on a U300. So if in our diabetes world, if the typical strength dilution isn't working, then they go to a higher strength, U300, and then U500. And so she actually came off the equivalent of 90 units of insulin in one day.
Oh, wow.
And so,
Mm.
well, so the decision I had to make, there was a student with me, so I got to kind of explain it too, and was her blood sugars were pretty much normal, about 100, 110 milligrams per deciliter, around 6.5 millimole. But she was on 90 units of insulin, and she was eating 100 grams of carbs a day, 100, 150. And so I instructed her to cut all the carbs on the next day and just stop. Oh, she was also on one of the SGLT2 inhibitors, the other, Farxiga, I think, or, yeah, Farxiga. So I said, just stop those, measure your blood glucose, and text it to me. And she said, text the doctor? I mean, and I said, look, you're the only one at the moment that I'm helping get off insulin, so I don't mind. And that also kind of, I know she's not going to have to text me very long, so I don't get worried about that. So the next morning, her blood glucose was still normal, cutting the carbs and cutting all the medicines. Stay the same.
So
So
this,
the blood glucose goes up because of the carbs, and the medicine keeps the blood glucose down. So if you cut the carbs out, you get to cut the medicine out. And in her case, it was a judgment call. I decided I'd rather have it a little high, the blood glucose,
yep.
than too low. Oh, in fact, she had been having hypos. So the doctors were giving her so much insulin that she was having low blood sugars, having to take more sugar. And it was really hard to convince her or to explain that actually it's the carbs it's the medication that makes the blood sugar go too low. The doctors aren't really explaining that very well. And then, of course, she came in saying, I said, so what is diabetes? She said, well, it's when my body isn't making enough insulin. I said, no, wait a sec. No, we need to talk about what diabetes is. It's excess blood glucose. It's too high. It's not lack of insulin, as long as you're not a type 1. But yeah,
Yes.
it's really kind of a fun job. It takes a little effort at first. If someone's on 7 medicines, you need to work with people to get off that medicine. We call that de-prescribing. But even if you're like pre-diabetes, you're not on any medicines yet, that's the time to take action. If you're don't wait until you're on all of these medicines. But so I would like over time to help other doctors, who are working with people upstream. We call it upstream medicine, where you're not this sick. I mean, we can pull people out of the river down here, and I feel good taking people off 80 units of insulin, but we need to stop the carbs and the medicines up here.
Stop the insult rather than treating the symptoms, right?
Yeah.
If someone slightly exceed the carbohydrate threshold, would for whatever reason, for due to compliance or whatever reason, would that stop the benefit of? Would they get less benefit, or do they
Oh,
lose completely the benefit?
yeah. For it's a temporary pause, right? So um, there are two different diets that often get confused. There's a ketogenic diet for epilepsy, where children with epilepsy, children with seizures, can have a reversal of their epilepsy by following a keto diet. And they're very strict. Some children, if they eat a bite of a candy bar, can have a seizure. And that, grand mal or, uh, tonic-clonic seizures is dramatic, and you don't want those. If you're using a low-carb keto diet for diabetes and obesity treatment, you don't have to be quite so strict. And the consequence of having a carbohydrate is you might stop the fat burning for a day or two, or your blood glucose might go up like it had been every day. So uh, when people go on vacation, the holidays, it's common to be around family and friends who are eating carbs, and you can do that. The risk early on is that you get what we call a full-blown relapse
Yes.
back to eating all of the carbs that you used to. So the first holiday season, when people are going through that, we advise to be as strict as you can away from eating carbs, or have an appointment in our area. In January is a very busy month in a weight loss clinic because we're dealing with the relapse that happened for a lot of people over the holiday season. But I find groups that are used to fasting have a better time of it. And I was introduced to this in Indonesia. There's actually a Facebook group called Ketosis Indonesia, where they combine the largely Muslim country Ramadan fasting with not eating carbs when you do eat during, as a daily
Fasting
kind of
time.
thing. Yeah, in the U.S., I estimate I was in front of about 5,000 people on Saturday mornings. I went around the country and put on little meetings with local experts for Adapter Life and Adapter Life Academy. And it was very rare for someone to not eat 3 meals a day. So it's uncommon in our country to have someone experience fasting.
Mhm.
In fact, it's almost like well, you have to eat 3 meals a day with
Yeah.
snacks, don't you? Especially if someone has diabetes, they're taught this. And
Yes.
so in my teaching and the handouts, I handle that a little, I say, now, if you're not hungry, don't eat. And you don't have to eat breakfast. And people often go, what? I thought that was the most important meal of the day. And of course, that was the cereal manufacturers who implanted that in everyone's head so that they would eat their product. So the idea that you can eat less often and having a whole month where you wouldn't eat during the daytime, that's very odd for our country. So and I think it's a liability. I think if you're kind of used to not eating growing up, during the day, I think it gives you a little more flexibility. That's just my hunch. I'd love to see that studied, but my first introduction to like a whole community that would be combining keto with fasting was in Indonesia. And we were all invited to a meeting there before the COVID, and and it's still going strong. Of course, it's mostly in a different language, so I don't I'm not active in that group. But so you can think about combining the
Fasting
fasting idea with keto. It works particularly well.
or skipping meal.
Yeah,
If
yeah.
someone slightly exceeds the carbohydrate threshold, let's say they eat instead of 30, 35 or 40, um, does that completely lose all of the benefits or it
Oh,
makes it less beneficial?
well, so it may actually still be keto for that individual.
Hmm.
So the lower you go in the carbohydrates, the more likely you'll be in ketosis. And in a clinical population that I see, so it's an obesity medicine, diabetes reversal practice for the most part. I do see healthy people too, but and they're all adults because I'm internal medicine. Um, some people at 70, even 100 grams of carbs, if they're healthy carbs,
Athletics.
can be in ketosis. If you're young, you're active, you're exercising. I was on a podcast with Ben Greenfield, who has been around since 2008, talking about paleo, primal, healthy living. He was walking on his treadmill as he interviewed us. He's another, I don't know. I have a colleague who does that, but it's kind of
We should
weird in our
try that.
area. But so he's walking in and he says, you wouldn't know that I'm keto. He said, because I'm eating 100, 150 grams of carbs a day, but he's exercising so much and he's relatively young, I think in his 40s or 50s. And so it depends. And and just to push the idea of measuring ketones a little bit, I don't recommend it, but you can, and it's very helpful for a lot of people. So you can get a meter now for the blood glucose and ketones. It's the
Yes.
same meter, different strips. I think the common one that's been really good at keeping the strip price low is the Keto
Yeah.
Mojo,
Yeah.
Mojo. You can actually then, let's say, try 50, 75 carbs per day and check your ketones if you want and see what your threshold is. Back a long time ago,
And
one
what
of
is an
Dr. Atkins,
optimal level for the keto? If you would say someone would
well,
measure, what would you think is an optimal level?
so that's a great question. I don't think we know.
Hmm.
And in my experience, the ketone level over time, as you adapt to ketones, will come down. I think the early science that I'm following, um, if you're trying to deal with a severe mental health problem, or you're trying to treat cancer, and you want that ketosis, then you will want to be between 1 and 3 millimole, and but the range for obesity and diabetes treatment, I've seen people doing everything right, and their blood ketones may be zero point 0.3, zero point 0.5. And so the first teaching was between 1 and 3, and if you're not under, no, it's broader than that. And you could even use urine ketones, which is a semi-quantitative scale. It doesn't give you the same number, and it's checking a different ketone body, acetoacetate, is a good rule of thumb. If someone can't afford or doesn't have access to the blood strips,
Yeah.
I will recommend in our area the glucose strips, glucose ketone strips. But that's if you want to tweak. So if someone comes to me to, just stay to that list of foods, stay to page 4. If it's not on there, don't
Don't eat
have
it.
it, at least for now, But then over time, people want to eat off page 4. It's okay. You watch total carbs or you monitor your own ketone level. But then when you're at your goal, again, it's still, I don't know if it's better to be in ketosis all the time or not. And most people will add back some carbs because it's just so, common and comfortable. But if you're adding exercise, if you're a biohacker and you're measuring all these things, the relatively recent studies by Dr. Cooper, the blood looks great when you don't eat carbs for the long run, even when you haven't had a serious medical condition to reverse. So, so no, all is not lost if you add in some carbs, even even if you have a whole full-blown, you know, 200 to 300 gram carb meal. we did a study that we never published, and that was we asked people to have a cheat meal. I don't like that language, but everyone calls it that. And we had them eat 75 grams of carbs in one setting, and then we checked the ketone level. And it was a company that was using a breath monitor studying it. So I talked her into using breath, blood, and urine, and they hung together pretty well. So I don't, we use the blood as sort of the gold standard, but the breath and the urine can be useful as well. But some people were knocked out of ketosis, knocked out of ketonemia. Dr. Cooper called it the suck diet, the suppression of ketone diet, SUK. It's kind of funny, but people who are in ketosis, you have one meal. There were a couple people who were knocked out of ketosis for 2 weeks, not just 2 days like we teach. So if you have a tough metabolism, these were people who had been heavy since childhood. So the common story is
So
they
one
were
meal
put
will
on,
put them 2 weeks out of ketosis, just one meal.
yeah,
Oh,
yeah, and so what that means is that when some people try it and they're not really strict for 2 weeks, they'll say, well, it doesn't work. It's not working for me and all. Well, but you have to realize that no, you have to be strict for 30 days or 2 weeks to get
be
that ketosis.
because they're
So
severely insulin resistant, they got out of it for 2 weeks, or because of the addiction that they kept eating more
no,
carbs?
no, they were in this study, we knew they were adherent. And so the idea is that they were so insulin resistant
Oh,
that they couldn't get back into ketosis like we teach people who are not as insulin resistant. This will happen with diabetes as well, where becomes someone gets diabetes because they can't stop eating sugar, right? They're a sugar addict. So we teach someone to avoid all the sugar. Oh my gosh. And so after a few days they have some sugar, well, then they'll come back, it doesn't work. Well, so kind of the more difficult the metabolism, the stricter you have to be. And it's again, just be strict, and after a couple of days you're not hungry, and yet in some people they may need a couple attempts at it. I kind of feel like I'm teaching someone how to learn like riding a bike. The first few times you might fall over, it's fine, you'll get this. Most people who learn to ride a bike, careful because I've met people who don't know how to ride bikes, but and I'll just reassure, you'll try it again, and this time I need you to go all week. And even then, sometimes I'll bring people back to the clinic for that kind of accountability. And I learned actually how to do this in obesity medicine at a residential program where I saw people every day. They moved to town. They set up, there was a clinic where they walked downhill from the apartments where they stayed, and we saw them. That's how I learned to deprescribe the insulin, is that people would come in the next day, and, oh my goodness, it's coming down. We got to cut back on the insulin, and that's why I'm comfortable now with sending someone home with instructions. As long as they're measuring the glucose, I can pull back quickly on the medication. But I became comfortable doing that living or working in a practice that actually had people come in every day, so we could see the result of it in real time. It's almost like when a young doctor is used to being in the hospital, it's a big difference. It's a big change to go to the outpatient clinic where you give someone advice and then they don't come back for 3 months. Um, Most young doctors want that immediate feedback. Fortunately, now we can get that feedback with a glucose monitor
okay.
or a finger stick. But uh, yeah, the medical, I toggle between should I go back to the American College of Physicians, the internal medicine group that I started with, and yet all they seem to want to do is talk about medication. But well, now there are medications that for diabetes and overweight and obesity. But diet, don't forget about diet.
What are your
I don't
thoughts
know.
on these GLP medications, the Ozempic and Mounjaro?
Yeah, and occasionally I'll prescribe them if they're so popular now that some people think they can't do it without them. But most people, when I talk about here are the different options, and most people have never been in a medical weight loss program. And so I'll ask, have you had a doctor help you lose weight before? No, I haven't. Well, we have prescription strength diets. There are pills and there are shots and medications, and then there's surgery, and there are even programs you can buy with shakes and bars. You have to pay for those in our area, unfortunately. And then I'll say, well, if you've never considered any of these things, why don't we start with diet? If the diet clicks, and I'm going to teach you a simple version. Even if someone says, "Oh, I did keto, I did Atkins, it didn't work," I say, "Well, you haven't done this approach, and I'm going to make it as simple as possible. Like I mentioned, sticking to the meat, poultry, fish, and shellfish and eggs, and you can have cheese. And in my area, if you mention pork rinds, I have the plan actually is in a wall poster, and I'll point to pork rinds, and the eyes light up. I can have pork rinds. I mean, so the strategy is to try to show the things that people like that they
Simplify.
can have,
Mm.
even in the first visit, a little bit, just to show them it's not going to be as bad. But the GLP-1s and then the second generation, which is the GIP and GLP-1 agonists, clearly work. And they in a lecture I saw recently, colleague of mine in New York City basically gave the story of someone who owned one of the most famous bagel stores in the world, and he wasn't going to give up bagels, it was his ego and his world, and so the doctor put him on the shot, and he lost this weight, and to the perception of the store owner, he didn't really change his diet. He just ate a lot less of the bagel and all the other stuff that he was eating because the shot is so powerful. It basically mimics the feeling you have after eating a large meal. And that's where it gets into the side effects. What do you want to do after you eat a huge meal? You know, nothing.
Yes.
You want to sleep, or so some people are so affected that they don't really have fun anymore, or when they're on it, and the nausea early on affects about a third of the people, so two-thirds don't, and most of my friends will give a Zofran as an anti-nausea pill at the beginning to say, and if you need this, here's a prescription for that. So they're treating the side effect of the medicine with a medicine, which is kind of like what internal medicine has become, right? So the concerns we have, as I'm past president of the Obesity Medicine Association, which has 5,500 doctors now in the U.S., you can actually sit for another board certification at the American Board of Obesity Medicine, and you'll learn about all the diets and the shots, pills, and surgery. And the main concern we have is if you don't get taught what to eat,
You will
and
regain
if you're
weight.
not, well, the muscle mass loss is the
Yes.
kind of Achilles heel. So, the medical world learned through the weight loss surgery experience that you could have people lose 200 pounds in 2 years, even more than that. But they also lost muscle. And it's very difficult to regain muscle
Muscle.
over time. So that's kind of the precious element of obesity medicine. We want to preserve muscle mass as much as we can, especially in older people. So if you don't teach people what to eat while they're not eating much, Kind of like that bagel store owner, though. I'm not happy with my colleagues saying that that's okay because they're not getting a lot of great nutrition when they're using the shot. And kind of like the metaphor of if you have fish and there's dirty water, oh, just have them put them on a shot, they'll have less dirty water. That in the long run, that doesn't help the fish. So there's a difference between losing weight and losing weight in the healthiest possible manner. You want your engine to be running smoothly, even when you're drawing upon your body fat and losing weight. And that separation is not commonly known. Most doctors will say, "Ah, you're losing weight. That's great. But doctor, it's 50 pounds in a month. Oh, that's fine." Well, that means they're
Yeah.
not only losing fat, they're losing water and they're losing muscle if you're losing that fast. So about 1 to 2 pounds per week, maybe 3 pounds per week is kind of the upper limit for, of course, the heavier you are, the more weight you can lose in a healthy manner. But so that's one of the concerns with the shots we have today. They're so good. And if people aren't getting taught what to eat, when you do eat the healthiest food you can, then we have concerns. It's played out a little bit in the research showing the muscle mass loss, but in the long run, longevity and health is actually predicted by how much muscle you still have. So that's the concern is it's not helping people lose weight in the healthiest way possible.
Yes, and 9 out of 10 people who are on the injection and they stop it, they regain the weight. What do you advise to people who are on these injections and planning to get out of it? What do you advise them
Yeah.
to take an approach that they don't regain the weight back?
Yeah, so I think the language is now, how are you going to off ramp? How are you going to get off the shots? And so most obesity medicine programs that are, at least we teach people who run the programs, along the way, teach your patient. So if you're on a shot, learn what healthy eating is. And it means, eat what you're made of, which is protein. So it's not fruit. But I thought fruit was healthy. No, not when you're trying to lose weight. No, fruit's not your friend. But so learn about protein coming first. And if you need a pattern to follow of eating, a pattern of eating, the lower carb ones, the Mediterranean diet, the low carb or keto diet, these are great off ramps from getting off the shots. And even there's a growing trend in the US where it's even so simple, the off ramp is just eat a carnivore type of diet, meaning just meat. And the simplicity of that actually helps a lot of people because they're just so confused about what to do. And I think it's reasonable compared to other options we have that a low carb, low glycemic, Mediterranean, these are the way you don't want to go back to the same way of eating that got you where you were before. So while you're on the shot, learn about the diet. You might not have to implement it, but when you're going to transition off it, some doctors are talking about, just microdosing a little bit here and there. I mean, I, there's an old kind of saying that you don't want to mess with Mother Nature too much. There's a lot we still don't know about injecting ourselves with this incretin. It's basically a hormone that comes out of your intestines. So I try to get people off the medication, transition them. But in an interesting study out of Stanford University, the other extreme seems to work really well too. So I'm talking about low glycemic, high fat protein diets. If you do an ultra low fat, high carb diet, if you do that correctly, that can work too. So it seems to me like it's in this middle ground, like almost like you can drive on the right-hand side of the road or the left-hand side of the road. Don't go back and forth, in the same country. That's not going to work. So a lot of the diet, which is best and all this, nobody really knows. And some of it is just what within the healthy options we have, you want to choose one that wasn't the one that got you in trouble in the first place, and
Yes.
then one that you can stick with, that you like the foods or you like the way it makes you feel. Most people stick to a keto diet just because they feel better. I mean,
Mhm.
I in my clinic, I feel like I'm 40 years old, and they're 70. So the how you feel is an important thing to consider, um, uh, independent of how the blood looks and what the food is on the plate.
Do you have any thoughts on fiber-rich diet?
Well, fiber is one of those things that really doesn't have a whole lot of science behind it. I mean, to say here are randomized trials of fiber, no fiber, and here are the benefits. Those studies have been done to a certain degree, and when there are randomized trials, adding fiber doesn't seem to do much, if anything. I mean, it really doesn't reverse colon cancer or prevent it, even polyps. So fiber is kind of one of those things that gets a lot of attention, but I don't really have much worry about it. If you think of regularity, having a bowel movement at a certain frequency, then fiber may be important to have. On a program like I teach with 2 cups of leafy greens and 1 cup of a non-starchy vegetable per day, people are getting some fiber in there. If you do a strict carnivore version, then you are not getting much fiber. But that doesn't concern me medically over time.
What are your thoughts on almond milk or almond flour and nut extract in general?
Yeah, so the almond flour and nuts in general, nut flour, so it could be coconut flour. At first, I don't let people have them, or I recommend that they don't, and because of that trigger food element. Although over time, as people have more, so if you come to it, you're not trying to reverse diabetes or obesity, and you're really just trying to lower the carbs. You're not even trying to lose much weight. I think they're fine. But in a keto kind of maximal weight loss approach, I discourage it at first. The nuts, nut flours, and even I don't like the idea of having oil being added and tons of butter being consumed, unless you're at your goal and you like doing that. There are some people who teach that, and if you're trying to lose fat off your body, you don't want to be eating tons of fat, lots of fat.
So almond flour you don't like, and what about almond milk?
Well, but the almond flour might be fine. Just if it's
Mhm.
prescription strength, then no. Yeah, almond milk. Um, so this gets into it's not on the page. So if it's not on the page, then you look at the total carb content. And sort of like the almond flour, unsweetened almond milk will be fine for most people because the total grams is less than 1 per serving. So, but for some people, if you have milk in the refrigerator and you're used to, going like this, so it's the serving size that matters. Like me, if I have a jar of peanut butter or candy like peanut M&Ms, I can eat the whole package and more, or the whole jar. And so you want to be careful if you can't moderate the almond milk. But unsweetened almond milk, even other ones that I'm not familiar with, you always want to just look at the total carb, not net carbs, for the serving you're having.
Mhm. And some food that are traditionally unhealthy, possible to make in healthy ways if you choose different kind of flour, like the almond flour.
I've seen my patients use all sorts of variations to make different types of flatbread, whether it be tortilla or pita, or using egg whites or Parmesan cheese. You can look online and find lots of recipes for these different things. Uh, the substitution so substitutions for high carb foods is kind of a category that I don't really talk about at first. Most people will be comfortable without hunger and cravings just by following the plan. So I don't force people to learn about how to make bread or flatbread or pizza with the almond flour or other even the pork rinds or chicken rinds can be used in a pizza crust. We have a, a tradition of making waffles with carb batter, and now there's something called a chaffle with cheese and eggs as the base, but you put it in a waffle maker, and that can make a nice bread or pizza substitute. For rice, the tradition is using cauliflower, chopping that up as cauli rice. If you use it, if you use fresh cauliflower and then put it in the microwave, you can actually make small amounts very fast. Of course, you want to flavor it with something else, but you'll get the rice or couscous type of texture. A lot of people are texture eaters, and so
Yes.
I'll ask people maybe a month in, what are you missing? And then try to target individually. So I wouldn't tell you how to make a bread substitute if you didn't crave bread, right? So a lot of people crave fruit or fruit flavored things, and even I'll say, well, look up the carb content of fruit and berries, and if this is a cup, then that's half a cup, and that's a quarter cup, and so a quarter cup of fruit and berries has 5 carbs. You can look it up, 5 total, not net, and so you could have under 20 or 30 per day, you could have a quarter cup of berries. Most people will look at that and go, well, that's not much. And then they decide just, I won't even have it at all. But there are some compromises and substitutions you can make to make it easier along the way for people. Pasta is a common one. And I was at a restaurant recently where they made pasta out of cabbage that it fooled me, in
Mm.
fact, that I thought it
Yeah.
was real pasta. But there are other companies that are using konjac root. It's a different source to make all kinds of pasta and even rice as a substitution. But in general, I try to make people comfortable with a new set of foods rather than trying to recreate, grandma's cooking, that had lots of sugar and starch in it. But, I have had a cake that used pulverized pork rinds instead of flour. And so all sorts of creative things that you can do. And just watch the total carbs for the day.
Could you give us some more examples of creative substitute?
Yeah, so I'm seeing, it's interesting because I don't cook a whole lot. So me personally, but I think that's a strength because most of my patients, well, there's an era now where most people don't even know how to cook. And so one of the things I want to bring in is that there are some people in my town, they only go to fast food restaurants. And their eyes light up when I say, you can go to McDonald's or Burger King or whatever, but you just don't eat the bread. Or you eat the burger without the bread. You don't eat the fries and there's no sugar in the drinks. And to my surprise, one of my patients only ate fast food and lost 100 pounds. And I didn't teach this as a clean eating way to do it, but I have to meet people with
Needs.
where they are. Um, so that's another kind of domain that I get into just because it's so common that people eat at restaurants. And then, of course, in our area, the Mexican cuisine is very, very popular. And so you would stay to the meat and the grilled veggies. You have kebabs or hero meat without the pita. You get a Greek salad on the side with feta cheese and olives. Um, so I teach a lot of not how to cook personally, but how to navigate it's become so common in our area, I think worldwide even, for people to go out to eat. Um, the Some people even come up with substitutions to make even like taco shell sorts of things. And I would just encourage you to find a website or teacher, influencer online who has a style of cooking that you like. In my experience, there's a website that's free called Linda's Low Carb, Linda's website, low carb recipes. And it's been around about 20 years and it's still very simple. It can teach you how to have uh, just pouring, like tomato type of canned ingredient onto chicken and calling it Rotel chicken, or some. Um, so my style is to try to keep it simple. Although my book called End Your Carb Confusion teaches 3 levels of carbs, and we have a chef who made a companion cookbook called End Your Carb Confusion, the cookbook. Scott Parker's on the cover. He's the chef that he put together a really nice, clean eating. If you like to cook and you want to learn from a chef who had been in restaurants for 20 years now, teaching you what he does at home, that's a good resource as well. End Your Carb Confusion, the cookbook.
Yes, we will link all of your books and all of your great work. And also, you have the channel where you teach a lot as well. We will link that as well. And what about
Thank you.
supplement use for unhealthy drinks?
Well, sugar is sort of the demon. Okay, so the we measure blood sugar when it comes to diabetes. We don't measure blood seed oils. We don't measure, blood coconut oil, or So the obvious thing is to get rid of the sugar in the drinks or minimize it. If someone is so, I've had this much honey in my tea or coffee all my life, and I calculate, okay, that's 2 grams of let them have it. So,
Mm.
so I think it's the amount that matters, not it's not like arsenic poisoning or I guess like a cyanide where a little bit's going to kill you. No, no, it's more in grams and the reality is we have about 5 grams of sugar or glucose in our bloodstream at any given moment, not milligrams or micrograms. So you can get away with a little bit of sugar that I allow kind of calculate again how much people, the personalization of it, how much people want that. Um, uh, Now I forget your question. I'm
No, I asked
sorry.
about are there substitute for unhealthy drinks or
Oh, right.
yes.
Well, and this is a bit of a controversial thing, although it's not controversial to me. Just have something that doesn't have sugar in it.
Hmm.
And of course, that means, so I've been teaching people to use Splenda, aspartame, any kind of non-sugar sweetener. Yes, monk fruit and stevia and allulose. I think all of these are a better choice than sugar. And I don't really agree that, with a lot of influencers who teach perfection, you have to have perfection. I don't agree. In my experience, I deal with a lot of people who aren't perfect. Well, nobody's perfect.
Yes.
So the reality is I need to get people off that. If it's a sugary drink, I'll transition them to sugar-free drinks or foods. There's a sugar-free gelatin that is very commonly consumed here, Jello, gelatin. It could be any brand, but that's very helpful. I teach people how to make a no-bake cheesecake that is basically a cheesecake without a crust that you put in the refrigerator. So you want to, I'm not familiar with all of the new kind of energy drinks. I think if someone's used to having an energy drink with sugar, I just say try the sugar-free version. And
Mm.
even these sports drinks now, all of them have a sugar-free version. So yeah, I think water is best. It's also if your water in your area is potable, is drinkable, that's cheapest too. Um, Some people go to lengths of having double filtered osmotic water. Okay, if you can afford that, in our area, tap water is drinkable, and yet bottled water is fine as well. But you just want to get the sugar out of the drinks.
Yeah. And is that restriction and that trying to perfect what makes people go out of their healthy eating and go to bad route again
Well, you
and
know
bunch
what?
eating, right?
So I was teaching this approach for 10 years. And people started coming in, oh, that's so hard to do. Well, what do you mean? They said, well, keto, it's hard to do. I thought, well, what's keto? Wait a minute. And so people started coming in doing all these things that are difficult, using apps, and the app told them to eat more, or you're not eating enough, or measuring things. And well, I'm not in ketosis. And no, that's not the goal. The goal is to actually have results. So I try to keep it as simple as possible because simple really does mean sustainable in the long
Yes.
run.
Yes. And I want to ask you your thoughts on seeds like chia seed, pumpkin seed, flax seed, sunflower seed.
So, I still look at the carb content. I
Mhm.
think those are fine. The studies that we did were before the beginning of the kind of paleo primal seed oils or no, excuse me, not seed oil, seeds. And so I'm not sure of their added health benefits beyond just keeping the carbs low, but I think they're fine. And if you think you're helping something, great. There are a lot of things like bulletproof coffee came out way after our research, and people would start coming to me saying, and I can't afford the bulletproof coffee. I said, what's that? I never told anyone to put oil or butter and put, and you have to have the special, really expensive coffee. No, 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 no. So all those things are interesting, but I don't incorporate that into my teaching. If someone wants to do that, they're keeping the carbs low. It keeps the hunger down. Same thing with kind of added ketones. I just don't know enough. And the studies haven't been done really to look in the context of an entire day.
Like the
If someone
MCTs? Like,
adds, yeah, MCT or even ketone pills and drinks, you might raise the ketone momentarily. And the argument is, well, add some MCT, it'll help the ketone enzymes get going. There may be something to that, but there really aren't the research studies there for me to be comfortable in making that a confident recommendation.
and it also becomes pointless if the insulin and blood sugar is higher, I guess, right? We don't know.
Well, we don't know, and there's some very interesting research, again, kind of early uh, um, preliminary research where even infusing ketones, without the diet change, might have beneficial effects. So it's going to be fascinating to see that play out. One prominent retired doctor started her husband on coconut oil, on the cornflakes, on cereal, and it improved his Alzheimer's for a year. So that he went from a very disordered clock face where you measure how bad someone's brain is functioning to, write a clock. And he wrote, the clock perfectly just by putting coconut oil, having that ketone elevation on cornflakes. So he was actually eating carbs. So, but the effect wore off over time. And then when she learned about a keto diet, this is Dr. Mary Newport, and when she learned about it, she put him on the keto diet with the coconut oil. But it didn't have durable effects, but it did have some effects. So that I think means we need more research on it. And the problem with a grassroots movement like we see is that you might have an anecdote or two, a story or two, and you might even have your own experience. But that doesn't give us confidence of how well it's going to work in 100 people, for example. And as a doctor, I want to be confident with what I recommend, not, well, this might work, and
Based
but
on
Well, and so then the other thing about, okay, MCT, ketones, apple cider vinegar, it takes my hunger away, doctor. People tell me, well, but how much does it take it away? Are you eating enough? So if you perturb normal appetite control, now it's like taking a shot or a medicine where you're not allowing your own body to figure out the metering or the amount, the dose of food to consume. Really, I'm kind of a holistic, let the body heal itself without these supplements as best you can. I think that's kind of the overarching theme. I'm not a big supplement, even take these nutritional supplements advocate until there's science to say that it's really
Subtraction rather than
useful.
adding, right?
Yeah,
Yes.
yeah.
And what among the most common labs do you do for your patients? And what are some laboratory markers you look for?
Yeah, so if someone comes to me as a specialist, in our area, they've gone to a lot of primary care or family doctors, GPs, and a lot of them have already had the testing that I would recommend. It's really just like general internal medicine, a blood count, CBC, the complete blood count, a chemistry panel with liver functions, thyroid testing, and I do three thyroid level, the TSH, T3, and T4, which I don't just use the TSH as a screening tool. And then in the blood sugar domain, it's glucose and insulin. Well, I don't always get insulin if someone has had it done lately, and then the hemoglobin A1C is a marker of 3 months of the blood sugar, but commonly that's already have done by some other doctor. The mindset that, or my approach, my perspective is if someone chooses to do a diet like this, I'm pretty confident that all of these things are going to get better.
Mm.
So in some people who are strapped for money or come from a distance I might not even measure anything.
Mhm.
How is that for dramatic? I mean, so a lot, I have some colleagues who they make a little bit of money on every blood test taken. They recommend all of these blood tests and they all get better. There are some people out there now who are into the sale of medical laboratory tests without giving any advice about them. And I don't think that's necessary. So my early training was in the Veterans Affairs system, which is one of the biggest healthcare systems in the U.S. Veterans Affairs taught me and teaches today stewardship of resources. And if what you were going to test didn't change what you did, we were less apt to test it. So the method that I use is not a drug. It's not a surgery. If you get weight loss surgery, they send you to a psychologist and a dietitian, and it's like a big intervention. It's a huge deal. All I'm doing is helping people change the food. And so a lot of the labs I get at first are to keep making things safe. If someone's been on a medicine, I want to make sure it's safe. Over time, I do shift more toward the inflammation side of testing, or if someone needs persuasion to lower the carbs, I might check a C-reactive protein as a marker of inflammation, insulin as a marker of insulin resistance. I'm moving away from the standard lipid panels. If someone does get a lipid panel and it's done all the time in this area, I explain that we don't look at the lipid panel in the same way, the cholesterol levels. Uh, we don't look at the total and LDL. We look at the triglyceride and HDL. And that's a big surprise to not only people, but their doctors in my area. So that one, just about everyone has already had lipid panels done before they come to me, and I just have to explain, take some time, educate that we look at it a little differently. You want the triglyceride low and the HDL as high as you can, and by eating more fat and cutting carbs, that HDL will typically go up over time. But so, I'm even now with the cardiometabolic risk assessment, I'll be asking people more about the arteries. What is the status of your pipes, of your arteries? And they'll say, well, my doctor said it was fine. I said, well, did they look? You know, it's almost like, people, oh, you're fine. No. So in our area, a lot of people just, a lot of doctors wait till you have a symptom before they do any evaluation of the heart. Although if you were an executive, you might get an executive physical where you get on a treadmill every few years and you're searching at least a little bit for underlying silent disease like coronary disease. That's where I now talk a lot about the calcium score, the rapid CT scan, or doing ultrasounds. But that measurement doesn't have anything to do really with the diet teaching that I'm talking about. It's more now philosophically, how do I help this individual in a preventive way? And then don't forget that the diet change is a huge preventive, not only therapeutic, but preventive measure. And so when my patient goes to the doctor and the other doctor, they say, you need a drug for this. I coach them to say, but I'm changing my diet for this. So the diet is actually intervention that is as potent as a drug.
Do you measure the advanced lipid markers like lipoprotein ApoB and lipoprotein A? And do you have any thoughts on them as well?
Well, those get better too. So the standard lipid panel is most commonly done in my area where it's a calculated LDL, which is terrible, of course. So the advanced lipid profile, for years I would do that, but it doesn't always clean. It doesn't always get squeaky clean, even on a low carb keto diet. But yeah, the intersection of the insulin resistance and the cholesterol models of disease is that LDL size, the LDL particle number. You want the LDL to be higher. You want the small LDL to be as low as possible. But after, I used to do that routinely, but people would then come in and say, "Well, it's not no, it's not zero." I'm like, well, so I don't know. It's possible that you could add medicine to a keto diet and make it better for cardiometabolic risk reduction, but that's an assumption. And when a doctor is assuming that, well, when you eat carbs and your LDL and cholesterol looks like this, we give you statins and other medication. When they assume that that's going to always help someone on a keto diet, that's an assumption. So the metabolism is very different. And in a scientific setting or doctor to doctor like this, we might actually be making people worse by assuming that a medicine that stops cholesterol production, even the PCSK9 inhibitors, the monoclonal antibodies, to assume that that's necessarily going to be helpful among those who don't eat carbs, we don't know. And until we know, we shouldn't blindly follow that, I believe. I mean, that one-on-one, I can teach that and artfully dodge the. But my doctor said, well, they haven't been trained in this. They really all they know is drugs. And most of the time people will then settle on, well, okay, I want to know if I have atherosclerosis. I had people coming to me with evidence they had no atherosclerosis at age 75. And yet their doctor wanted them on a medicine to treat the cholesterol in the blood, which is a marker and predictor of atherosclerosis, a disease they didn't have. So, I mean, that's crazy. An oncologist wouldn't give chemotherapy unless you had tissue diagnosis of cancer. So in my area, doctors are in the and recommendations are in a routine of, well, we just assume you have the disease and here's the pill based on a cholesterol level. No, we can know now, select people. Often they have to pay out of pocket, sadly. They can know if they have atherosclerosis or not. And especially if you lived, had someone come in, he was 90 years old, and the doctor wanted him on a cholesterol pill, and he had no evidence of atherosclerosis. No, he had two less than 20% lesions on his LAD. So he had these little, like, I don't know, bumps on the inside, like little pimples on his artery, and he's 90 years old, and the doctor still wanted to put him on a medicine for the cholesterol. When I explained that to him, I said, well, in the next 90 years, you're going to get another two little pimples, you know. Anyway, I'm afraid maybe there's not enough time to think about this through with every person, or they just want to follow a guideline. And I don't know. That is part of it. It's doctors want to do things that are relatively quick, but it should be effective and certainly not causing harm.
If someone lipid markers gets worse by through a ketogenic diet, and would you try to reduce the fat intake or adjust anything in their approach, or how would you approach it?
Well, let's take the metaphor of driving on the left-hand side of the road or right-hand side of the road. They both work. You don't want to, well, I was traveling from one country where they drove on the left and then to the right in the same day. So it's possible. But in general, you want to do one way or the other. So if you're going to kind of go all in with the idea that it's insulin resistance, it's the triglyceride HDL ratio, it's your HOMA-IR, the glucose insulin, the multiplicative product there. So your insulin is super low. I don't think it's worth changing the diet to lower the LDL that is the old paradigm. I mean, that would be like looking for the sign on the left-hand side when you're driving on the right-hand side now. And I know, there's some papers published, and some of my colleagues don't feel comfortable with an LDL elevated, and they'll tell their patients to eat a little more carbs or adjust the saturated fat. But are you treating a doctor's comfort level? I mean, again, the Stanford study I keep pulling out, because if you were at both extremes, insulin resistance went down equally. They had the same effect. So I don't worry. I try to explain about the cholesterol level, and rather than adjust the diet, if someone's liking it particularly, I shift toward the blood markers to the arteries themselves, if at all possible.
Tell us about your book, and if someone wants to learn more from you about your channel and anything you would like to discuss as well.
Yeah, so, after 25 years of doing studies and seeing people in my clinic and teaching other doctors, I just want to give people the comfort and the confidence that this is not like being on the edge of a cliff, that you're falling off. And being in ketosis or euketonemia is actually a very natural thing. And even though it wasn't normal in our lifetimes, I contributed on several scientific books and lots of scientific papers. There is a textbook out now called Ketogenic, the scientific basis of therapeutic carb restriction. It was edited by Professor Tim Noakes in Cape Town, South Africa, and we contributed chapters in that. So as a scientific tome or a resource, Ketogenic is a great textbook. That's really more for the scientists. For the general public, my latest book is called End Your Carb Confusion. It's going to be teaching you about carbs, what they do, the blood sugar, but then also gives you very practical lists to follow. And it's based on what I've been doing in my clinic for a long time. So my company, my company, Adapt Your Life, And Adapt Your Life Academy teaches people how to do low carb, keto, and this next month, it's open now for getting on a wait list. We're going to be teaching the carnivore diet, which for some people is particularly effective for autoimmune conditions. And the Adapt Your Life Academy teaches worldwide. We bring people into a course. It's all video content, although it also PDFs, it's written material, and we help people in a real-time sort of social media group to get over the hurdle to get started if that's needed. And so Adapt Your Life Academy is a very practical way to learn about this sort of thing if that interests you as well. So I've tried to help in the professional world, doing the research and teaching other doctors, but I also in a clinic and now through Adapt Your Life Academy want to help people one-on-one if you can't get to the clinic or to a clinic of someone who understands this. So thank you for asking and thank you for having me. I'd like to support whatever you're doing. And I do have a friend who has been trying to get me to the Middle East.
Yeah.
So I think there was actually a inkling of a meeting pre-COVID.
We would love to have you here. Actually, the obesities are quite a problem in the Middle East, and especially in the GCC region, the incidents are very high. And this kind of teaching, you sharing, being kind enough to share the knowledge will help a lot of people. We put Arabic subtitles in all of our videos as well.
Great. Well, I wish you all the best.
Thank you very much. And where can people order your book? You mentioned your book.
Any, any bookseller, Amazon, and then there's a companion cookbook called End Your Carb Confusion, the cookbook.
We will link all of that and also your YouTube channel, which I watch as well.
Right, right. So the YouTube channel is Adapt Your Life or Dr. Eric Westman, and I do a lot of reacts
Yes.
videos to other people, and that's actually been a lot of fun. And I read a lot of the comments and going to start replying to the comments, and so we give a lot of free, hopefully useful content at the Adapt Your Life YouTube channel or Dr. Eric Westman YouTube channel. Thank you.
Yeah, well, thank you very much for all of that. And thank you for all of your great work. We can have you again here in the future.
My pleasure. Happy to.
Okay. Thank you very much, Doctor. Thank you.
Bye now.